I'm joined today by Professor Saul Myerson, who is a consultant cardiologist and head of cardiac imaging and cardiac physiology at the John Radcliffe Hospital in Oxford. He's also an associate professor in cardiovascular medicine at the University of Oxford. So I'm very grateful for him for sparing his time to speak to us today. Just before we go in, when Charles Feeney and I were talking about this spring seminar, I said we should do a talk in cardiology because lawyers find cardiology in cardiac cases difficult. I include myself. I'm pleased that Lisa's nodding at the back. I include myself in that. You know, most lawyers know that the heart has 4 chambers and it pumps blood around the body, and that's probably about it. And then we speak to cardiologists and sort of leave the conference probably not much the wiser. So I've had a number of cardiology cases recently, and I thought that it would be a good opportunity to speak to everyone about them, those being atrial fibrillation and angina cases, which I've chosen. The structure of this seminar will be based upon the 2 case studies, which you should hopefully all have in front of you. But before we go into those, I did just want to bore you with a few statistics, if I may. Now, you probably can't see those figures very well. I apologise for that. But just so that you're aware, these are the most recent NHSR statistics. And for the year 2022-23, there were 203 new cardiology claims. Now, that is a decrease from the high point of 2019-2020, which was 229 cases. However, it is significantly higher than 2010, which was around 109 cases. So that chimes, and we've just been having a very brief discussion now about whether or not Professor Myerson has seen an increase in the cases he sees dealing with breach of duty as opposed to causation, because ordinarily cardiologists get involved in causation on most of the cases. So it does seem as though there is an increase in the number of cases against cardiology. It's still obviously way down on the other specialisms, which you would expect. I found an analysis by the MDU getting to the heart of cardiology claims, spring 2021. This was quite informative, but it does come with a bit of a health warning. One, because it's from the MDU, and for a statistical analysis, it was interesting that the author didn't actually think to include the number of claims which derives the statistical analysis. But there are some trends that we can see. As they say, 82% of their claims were successfully defended and only 18% was settled. The classification was extremely broad, you'll see. It was a claim for compensation or simply notification. That probably gives rise to a slightly skewed statistical analysis. But the most interesting point is these figures here. So the top 2 bullet points, incorrect or inadequate treatment, they form 20% of the total claims, 15% of which were settled by the MDU. And delayed diagnosis or treatment, 17%, of which 40% were settled by the MDU. That's very interesting and really chimes a lot with the cardiology cases that I've seen, and probably does chime with the cases that you are seeing as solicitors more at the coalface. It does show, though, an interesting pattern, I do think, which is consistent with most areas of clinical negligence cases, which it's a delay in diagnosis or treatment which forms the greatest risk to defendants, in my experience, anyway. So before we move on to the case studies, which is how we want to structure this, I want you to think, as we're going through, some questions have been posed, but they're more medical questions. From a legal perspective, if you can think about the law of causation and what causation requires you to prove, especially as regards to a hypothetical situation, because these are all going to be hypothetical, especially if an individual has died. What would the reasonable cardiologist have done? And we know that that's the test, of course, from Belitho and the other cases dealing with it, the Cambridge fertility case in particular. Right, so I will introduce the first case study, and then Professor Myerson will take over and deal with some of the medicine surrounding it. So the case studies are on the screen, but you have them in front of you. So what we have here is Claudius, who is a 55-year-old male. He's a HGV driver, and he has a past medical history of previous excessive alcohol consumption. He drank significantly between 2005 and 2010, owing to personal and professional difficulties. His brother passed away, which was what caused his drinking to start. He did have a liver test which showed raised liver enzymes in 2008, but since 2010 he's significantly reduced his alcohol, but he does still enjoy a bottle of red wine, perhaps two. He also suffers from hypertension, which was diagnosed in 2011. He's taking bisoprolol for this. On the 1st of April 2019, he had a routine knee arthroscopy, and he was admitted for surgery the day before. He was nil by mouth from 6 in the evening. He usually takes his bisoprolol at 8 in the morning, but he did not take it on the 1st of April because of his planned surgery at 1 in the afternoon. Perioperatively, the anaesthetist noted that Claudius's heart was 121 beats per minute. On an ECG examination, atrial fibrillation was diagnosed, a repeat ECG was performed, which showed a remaining high heart rate, but surgery proceeded in any event. The general practitioner was not informed of the diagnosis of atrial fibrillation. On the 1st of August, Claudius went to see his general practitioner regarding back pain. He takes his heart rate, it was fast. The ECG performed was suspicious of atrial fibrillation. 24-hour heart rate monitor was requested. It showed one episode of atrial fibrillation lasting 90 minutes, which resolved spontaneously. A referral to cardiology was made on the 7th of August. On the 9th of August, Claudius had a stroke, leaving him paralysed down his left side, and he also suffered from impaired vision. Okay, so claims brought against the hospital, alleging failure to inform the general practitioner of the atrial fibrillation, and that constituted a breach of duty. It's alleged that but for the breach, Claudius would have been reviewed by a cardiologist and commenced on anticoagulation, and he would have avoided the stroke. Liability is denied by the hospital. The defendant contends that it was reasonable to attribute the episode of atrial fibrillation on the 1st of April to Claudius not having taken his bisoprolol, and it is also alleged that a reasonable cardiologist would not have commenced anticoagulation. So that's the background. I'm just going to pass over now to Professor Myerson, who will take you through the medicine of this case study.
Thank you, Charlie. I thought I might just inject, not how to understand cardiology in 10 minutes, because that would be tricky, but just a little bit of background about atrial fibrillation and some of the evidence that we use in cardiology, but also a little bit about the condition, because I appreciate that cardiac conditions can be quite complex and they're not necessarily as black and white as some other areas of medicine. So a little bit of background on atrial fibrillation, why we might choose to prescribe anticoagulant medication, and what are the considerations that we have, how effective is it? Because that's really the crux of this, which boils down to, can we prevent the stroke that Claudia's had? So atrial fibrillation is an irregular cardiac rhythm, and although it's irregular and it can go fast at times, it's generally a stable rhythm. So unlike some other rhythms you may have heard of, it's not something that causes your heart to stop, it's not something that causes a heart attack, it just causes your heart to be irregular, perhaps a little bit fast, and so it's a nuisance. It can cause palpitation and it can be irritating, but it's not life-threatening. And it can either be persistent, i.e. present most of the time or all of the time, or it can be paroxysmal, so it happens intermittently, and actually the intermittent form is the one that tends to cause most symptoms, because if you're chopping and changing in between different rhythms, that's when you don't get used to it so easily, and so you might feel palpitation, for example. But not everyone is symptomatic, not everyone feels symptoms. It's quite possible that you've got atrial fibrillation and you don't know it. I don't mean you sitting here, because you're generally younger than I would normally expect atrial fibrillation to occur, but it's not impossible. I just mean in general, atrial fibrillation might be picked up incidentally, which it kind of was in this case. There are only two issues with atrial fibrillation. One is its tendency to go too fast. That could cause you to be breathless and to develop symptoms, or sometimes to develop heart failure. For example, if your atrial fibrillation is left running too fast for several weeks or months and you develop heart failure, that could be a reason why you run into trouble. The second reason is that the top chambers of the heart in atrial fibrillation are not moving as much as they should. So the blood flow is a bit more sluggish, so you're more prone to develop blood clots. And that's where this issue of thinning the blood with anticoagulation comes, because those blood clots, whilst they sit in the heart, don't cause any damage, but if they break away, travel through the bloodstream to other parts of the body, that's where they cause harm, or a stroke in this case. So when we have patients with atrial fibrillation, we will determine, firstly, have they got atrial fibrillation, and secondly, what their stroke risk might be once the atrial fibrillation has been diagnosed. This is the commonest risk score used. It's not obligatory to use this particular risk score, but it is, I think, mandatory to make an assessment of risk however you choose to do it by some accepted mechanism. So this is the CHADS-VASc score, which was an enhancement on the CHADS score, and it's called this because it's an abbreviation of the various factors, CHADS and then VASc for vascular disease. And the reason that you've got 2 sitting underneath the A and the S is because there are 2 potential points for each of those. So you can see the scoring system on the left-hand side here, and depending on your CHADS-VASc score, you are at an increased risk, or it determines your risk of stroke. The key thing that I think is really helpful to point out here is that this is an annual stroke risk. And you'll note that it's of the order of a few percent, mostly less than 10%, which is not negligible, but importantly, if you're talking about a case where you might have had anticoagulation for 2 or 3 months, the absolute risk of a stroke in that time is quite small, a few percent, perhaps 1 or 2%, even if you're at a high annual risk of stroke. And so there is no emergency. If you discover today that a patient has got anticoagulation, it is not obligatory to start anticoagulation today, even if you decide that it's indicated. It is quite reasonable to sit down with the patient, have a discussion with them about the pros and cons of anticoagulation in a month's time, for example, because the chance of an event happening within that month is tiny, and it's much more important that you gain the patient's consent and understanding. Now, in a perfect world, of course, you would have that discussion maybe a day or 2 later and really minimise the time, but in the real world, it's quite reasonable to have that discussion a bit later. And generally speaking, the point at which we think about anticoagulation is with a CHADS-VASc score of 2 or more. The reason for that is that that's the point at which the benefit of anticoagulation starts to exceed the harms of anticoagulation. As you might appreciate, if we thin your blood, we're going to increase the risk of bleeding. And so if you don't have a high risk of stroke due to a blood clot, and we thin your blood, then all we're going to do is increase the risk of bleeding into your gut or your brain or somewhere else, so we might actually cause harm. And I actually had, about 1.5 years ago, I had 2 cases that came to me. One was a patient who hadn't been anticoagulated and developed a stroke caused by a thrombus some months later, and the second one who had been anticoagulated, and the allegation was that they shouldn't have been because they developed a bleed into their brain some months later. So it was a really nice example of how it is important to sit down with the patient and explain why you want to start this medication, which might be potentially dangerous. The really interesting area is with a CHA2DS2-VASc score of 1. Clearly, if you have a score of 0, it doesn't mean 0 risk of stroke. It just means that your risk of stroke is so low, and therefore the benefit of anticoagulation is minor, and therefore not worth starting the anticoagulation. With a score of 1, you're in that grey zone, where it would be considered reasonable to start anticoagulation, but not mandatory. And that's where you take a lot of other factors into account. Now, the reason why I put male there is not because strokes are more important in men or anything silly like that. It's simply because I am not entirely sure why female gender, female sex, is listed in the CHA2DS2-VASc score. When you look at all the evidence behind it, if you're a woman, your increased risk of stroke is very, very small. It's statistically there, but it's very small. And when they went back and looked at the CHA2DS2-VASc score 10 or so years after it was introduced, they realised that actually it didn't make very much difference being female as opposed to being male to your overall risk of stroke. And so what they did was they said, right, well, we'll keep the CHA2DS2-VASc score because we want to be consistent. And we'll say, if you're female, but one of those points is for being female, then we won't count it, which just makes life really confusing. I would much rather, we said, right, let's just make it a 6-point scale, get rid of female sex, and then life is easy, and then everyone with 1 point or more is considered for anticoagulation. But they chose not to. So I can only apologise for the confusion. But it just means if you're female and the 1 point is for being female, then generally speaking, most cardiologists wouldn't be advising anticoagulation because it's not a strong enough risk factor to make it worthwhile. So apologies for the confusion. The other key points to make is, generally, it doesn't make a difference if you have persistent atrial fibrillation or intermittent or paroxysmal atrial fibrillation. They both carry the same risk. That's what the guidelines say, and that's what we generally do. However, it is true that there's a gradient of risk. So that if you have very infrequent episodes of atrial fibrillation, and they last a short time, just a few minutes every 6 months, for example, then you are at a low risk of stroke. And it would be entirely reasonable not to anticoagulate someone because you're at a lower risk. But I think in that situation, as a cardiologist, you would have to make it clear why you were deciding not to anticoagulate someone, and of course have that discussion with your patient. The other thing to consider is, if we're going to thin your blood, we want to make sure we're not going to put you at increased risk of bleeding. And so there's another score for bleeding called the has-bled score. You can see the way we go in cardiology to try and make life a bit more interesting, and so we can remember it. And again, you get a point or two for each of various conditions, and that increases your risk of bleeding. Mostly a score of 3 or more, which, as you can see on the right-hand side, that's the point where you start to significantly increase your risk of bleeding, and that's where we start to have reservations about prescribing anticoagulation. Just another couple of points. That was all about starting anticoagulation, and then the second part of that is, what does it do? Because that's really important. Anticoagulation does, in fact, have a substantial impact on reducing your stroke risk if you've got atrial fibrillation. About a 2/3 reduction in the future risk of stroke. So an enormous reduction in risk, which is unusual in medicine. And so, because you've got a more than 50% reduction in the future likelihood of stroke, if you start someone on anticoagulation, it is likely, on the balance of probabilities, that you will prevent a stroke in the future. Or I should say, had you started the anticoagulation, the stroke would have been prevented, assuming it's an ischemic stroke. If it's a bleed into the brain, clearly we wouldn't have made a difference. In fact, we might have made it worse. Now, mostly, it's just a small aside, mostly we're dealing with anticoagulation versus nothing. Occasionally patients are on aspirin or another antiplatelet drug for some other reason, but even in that situation, the additional benefit of anticoagulation over taking aspirin is still more than 50%, albeit only a little bit over, and so you would prevent a stroke on the balance of probabilities. It does come at a nearly twofold increased risk of hemorrhagic stroke, but because hemorrhagic strokes are much less common, the overall benefit is there. And all this data comes from the NICE evidence review, which is often a really good source if you want information on the magnitude of impact of any particular medication, be it statins or anticoagulation or anything else. If you look to the back of those very long-winded NICE documents and look for the evidence review, down the bottom you'll find some tables where they give you the relative risk of what will happen to you if you do or don't have these particular medications. And I find that very useful because they've nearly always sifted out the rubbish studies and kept the really good ones. The other thing to mention is about timing. I've already mentioned that it's not urgent to start anticoagulation. In fact, it's important to have that discussion with your patient. There's a second aspect to timing, which is that the impact isn't immediate. Although we might thin your blood within hours of starting anticoagulation, the problem is that if there's a pre-existing blood clot there, it doesn't disappear within hours. What anticoagulation does is stop new blood clot from forming. And that then allows your body's own system to get rid of that blood clot by itself. But that can take up to 3 or 4 weeks sometimes. So if I want to do a cardioversion procedure, for example, which involves delivering an electric shock to the heart to get you back into a normal rhythm, which we sometimes do in atrial fibrillation, I'll start you on anticoagulation to reduce the risk of stroke from the procedure, but I'll then wait a month before I do the procedure because I want to make sure that all of those blood clots that might be there have disappeared in that time. And so if you start anticoagulation today, I'm unlikely to prevent a stroke in 2 days' time because whatever blood clot is sitting there is probably still going to be sitting there in 2 days' time. So I appreciate that's quite a lot to weigh up in your heads, and that's where I often get bogged down in, well, not me bogged down, but I often cause consternation amongst solicitors because they're trying to get their heads around all of these different aspects, when it was started, etc. Clearly, in an individual case, it's normally reasonably straightforward. This is when the medication might have been started, this is when the event occurred, and so you've got some clear timings. So we'll get on to that just now, I suspect.
Thank you. So, there we have it. Okay, who's feeling brave?
I think you should start at the back row.
Yeah, so do I. Okay, so let's take these questions one at a time and then look at the case as a whole and decide whether or not we're running it as a claimant solicitor or defending it as a defendant solicitor. What was the cause of the atrial fibrillation, and was it reasonable to attribute it to the bisoprolol omission? Who has an opinion on that? Okay, well, I've got an opinion on it. And I'm sure Saul will help me. Is it reasonable in this case, looking at the history of atrial fibrillation, to say that a drug omission has caused an event which happened in April 2019, but then subsequently happened in August of 2023? So what do you think?
I think the short answer is no. I think the missing one dose of bisoprolol probably isn't going to cause your atrial fibrillation to occur. It's possible, but I think actually it was suppressing it when it was there in any case.
Yeah, I agree. As a non-cardiologist, I think in the facts of this case, if the facts had been that there had been no further investigation of the atrial fibrillation and the ECG hadn't been performed and then the stroke happened, that might be a stronger argument for the defendant to run, because the court would only be faced with one instance of atrial fibrillation in an instance where, albeit unusual as I understand it, it is not impossible for the drug omission to have caused the atrial fibrillation. But in this instance, because we have evidence of further episodes of atrial fibrillation, I don't think it would be reasonable for the defendant to argue that the April episode was caused by the omission of the bisoprolol.
I might add, sorry, that if you were to say that the omission of the drug caused the atrial fibrillation, really what you're saying is that the atrial fibrillation was there anyway, and it was just being suppressed by the drug. So it's not really that you're causing it, you're just hiding it with the drug. So even in that case, you really should have highlighted it to the GP to say, if stopping this drug has caused this AF to manifest, maybe there are other times that it's also manifesting and you might want to go look at it. So if I had been there at the time, that's what I would have done and say, you should be, I suggest that you look for atrial fibrillation at other times, because it may or may not have been just around the time of his surgery.
Whilst we're not dealing with pharmacology here, I know from this case as well that bisoprolol actually has quite a long half-life. I seem to remember it was about 24 hours.
Something like that. Yeah.
So again, it seems highly unlikely that the effects of the medication would have worn off with having missed one dose. So that seems to suggest that we're going to get home on breach of duty, and that the defendant is not going to win on breach of duty. Okay, so what in this instance, in this case, was the claimant's Chas-Fax score? Who knows? Okay, what were his factors that you would consider?
Hypertension.
Well done. So that gives us a score of 1 point. Is there anything else that you might look at?
Male.
Sorry?
Male.
Male? Would you look at that for?
Yep, no points for being male.
Yep.
His liver as well. Is an issue with his liver.
Yeah, that's an interesting one. So what about his red wine habits? So who thinks that that could give rise to a 1 point? Okay. So his alcohol consumption was quite some time ago, 2005 to 2010. He did have some assessment of his liver enzymes in 2008, and they were raised. If we just find Saul, what do you think about his drinking?
Drinking doesn't appear in the list of factors that increase your risk of stroke, so it won't alter your Chas-Fax score. What it does do is increase your risk of developing atrial fibrillation in the first place, but not the risk of stroke subsequently.
Okay.
So if you have a high alcohol intake, you are more prone to atrial fibrillation, but it doesn't alter your risk of stroke. What it might do is alter your risk of bleeding, because if you've got liver disease due to your alcohol, then your risk of bleeding is greater, and so you're making life complicated because you might have atrial fibrillation, but you also have an increased risk of bleeding. So it's a balance for the doctor to consider the best approach.
Yeah. So in this case, he's got a Chas-Fax score of 1, which means that anticoagulation should be considered. What's his Hasbled score, which we've just touched upon one of the points here? Drug or alcohol, 1 point. Now, Saul, help me with this. How much do you need to be drinking?
There aren't any hard and fast guidelines really. Which is why you'll notice it sort of says drugs or alcohol down the bottom there, which is about as vague as you can possibly get, really, isn't it? I mean, you can take a few paracetamol, too many. I don't think that's really what it means. I think what it means is an alcohol consumption enough for your doctor to be concerned that it's too much. Now, that doesn't mean that you're 2 points over the government's recommended weekly limit. It just means that your health is starting to suffer from the alcohol. That's the sort of threshold that I would use. So yes, it's got alcohol in there. He's got abnormal liver function, or at least he did have, and he's got hypertension. So he's got a Hazlitt score of 3, if you want to call it that. You would probably have some debate about the liver function because it was quite some years ago that he had it, and it's possible his liver's recovered a bit. But assuming his liver function is the same and his liver enzymes are abnormal, then he's got a score of 3. So he is at increased risk of bleeding.
So we're looking at a score of certainly 1, hypertension. The claimant will probably tell you until he's blue in the face that, you know, he really doesn't drink that much and that his bottle of red wine is, you know, medicinal. But
I'm assuming that's per day rather than per week.
Well, per day, yes. So you're probably going to have 1 point for alcohol consumption, and then arguably 1 point for his deranged liver enzymes. So we're looking at a high bleeding risk, but we're certainly looking at, numerically, the Hazlitt score is higher than the Chasvac score. Okay. So, what then, next question, would be Claudius's risk of stroke in a situation where he A, commenced anticoagulation, and B, he did not commence anticoagulation? So sort of rough and ready, about a 70% reduction?
70% reduction, so he certainly would have reduced it. The starting point without anticoagulation, so he's got a score of 1, so if I remember rightly from my list, that's about 2 or 3% a year. Next one.
Yeah.
1.3% per year on average. So we've reduced his risk from 1.3% down to around about 0.5%, thereabouts, which is why it's borderline. So it's not an insubstantial reduction in relative terms, it's a big reduction, but it's a difference going down from 1.3 to 0.5% or thereabouts. So some people would say, yes, I want to maximise my chances and take anticoagulation. Others would say that benefit doesn't sound good enough for me to risk bleeding side of things.
So who here, just as a general point, would consider Claudius to be at a high risk of bleeding? So he is considered a high bleeding risk according to the data, but does that risk outweigh the approximate 70% reduction in risk of a stroke if he commenced anticoagulation? So this would be obviously a factual case that you would discuss with the claimant. And so finally, we know that this is a case where it's alleged by the claimant that the referral would have been made to cardiology earlier, and that the atrial fibrillation would have been diagnosed, and he would have, if he'd have started anticoagulation, he would have avoided the stroke. So let's assume that he saw the cardiologist in approximately June, because the negligence happened in early April, and that he saw the cardiologist in June of 2019. Who here thinks that if he had commenced anticoagulation that it would have achieved the requisite level to prevent further clots being formed? Remembering what Saul said about how long it takes for the medicine to work. Yeah, I think that's pretty clear that he would have. What about in an instance where he had his surgery on the 1st of April 2023, and he had the stroke in August of 2023. And what if he saw the GP and cardiologist in about June of 2023? Who thinks that if he had been commenced on anticoagulation that he would have avoided the stroke? What do you think on that one, Saul?
I think if you've got 2 months, then the answer is yes. If it was only 1 month before a stroke, it becomes very borderline. And that's when you get into difficult areas. So I look at cases and really look to make it one side or another of 1 month, but obviously I don't get to choose when events might have happened.
Yeah.
So yes, I think at 2 months, that's enough time for the anticoagulation to be effective.
Okay. Right, there's a lot of medicine. Let's think about some law for a minute. Final question on the bullet point. Sorry, go on.
I was just going to add in, you mentioned a discussion between the cardiologist and Claudius. I would say that is best practice, not aspirational, but good practice. However, what happens most of the time is you sit down with a patient and you say, these are the pros and cons of starting anticoagulation. And it is in some ways unfair to then say to the patient, what would you like to do? Some people will have a strong view, and it's good to allow them the opportunity to have that, but most of the time they'll say, well, I haven't a clue, doctor, what should I do? And so what I often do is say, in his case, for example, I'd say, look, your stroke is modest, stroke risk is modest, your bleeding risk is high, so I don't think it's sensible to start anticoagulation because I think the risks are greater than the benefits. But if you are particularly worried about blood clots, then it's a reasonable thing to do as long as you understand you're increasing the risk of bleeding. A lot of the time what will happen is a cardiologist will write to the GP and say that, and say, I don't think anticoagulation should be started because X, Y, Z. If you then copy in the patient, you are effectively, firstly, informing them of your thought process, and B, tacitly giving them the opportunity to disagree if they feel they strongly about it. Now, I don't know whether that argument is strong from a legal perspective, but in terms of what medics are thinking, if you write to the GP or to the patient and say, this is what I'm thinking and this is why I don't think you should have this medicine, you are giving the patient an opportunity to respond if they feel differently. Not quite as good as sitting down with them in a consultation, but I think a lot of doctors would see that as informing the patient and involving them in the discussion.
Okay, that's very interesting. So let's take this in stages. I've not put any slides on this because I don't want to give the game away. Who here thinks that if Claudius went to see the cardiologist and the cardiologist took the decision not to prescribe anticoagulation, and he did so because he thought the bleeding risk was outstripped the risk of stroke, and that he chose that method of treating Claudius, who thinks that there would have been a failure to properly consent Claudius? You look puzzled, Richard.
I don't think so.
So, do you think there would be a breach of duty? You do. Who agrees with Richard? So, we know that the CHADSVAC recommendations is that you should consider, does it say that you should offer, which a score of 2 would give the patient Claudius in this instance? So this is the difficulty that now exists between Montgomery and McCulloch. So we know that McCulloch says that it is Bolam negligence as it relates to alternative treatment options, and that Montgomery has perhaps been scaled back slightly. So who, as a defendant, would run an argument to say a reasonable cardiologist would not have prescribed anticoagulation because he would have taken the view that the bleeding risk outstripped the risk of stroke, and that would be assessed on Boland basis as opposed to Montgomery? Who thinks that's a strong argument? I think that's quite a strong argument. I think that...
I have
go
a
on.
question that
Yeah.
maybe addresses it the other way round, which is, let's assume the majority of cardiologists, or the average competent cardiologist, would not have recommended anticoagulation. That's fine, but it doesn't address the Montgomery issue, which is, have you allowed the patient appropriate, or have you provided appropriate consent and information to the patient? Can you be in a situation where a claimant is saying, oh, if I'd had the choice of anticoagulation, I would definitely have gone for it after the event, because that's then saying, if only I'd had the opportunity, I would have said yes. But of course, there's no way of proving that, because it's only ever a conversation after the event.
Well, that's exactly what happened in this case. If the claimant says, had I been fully informed about the risk of stroke weighed against the risk of bleeding, I would have taken the risk. It's always wise to be, easy to be wise in hindsight. Whether or not the claimant would have is a difficult question. Montgomery still says that you have to provide fully informed consent, so it's raised the interesting question as to whether or not a reasonable doctor is Montgomery compliant. And if a reasonable doctor is Montgomery compliant, in this instance, should they not have discussed an alternative method of treatment? Okay. Who's running this case? I think I'd give it a go. Yeah, I think if you had a strong witness, the claimant, who is very clear that he would have commenced anticoagulation if offered, then you've certainly got a reasonable case. As I say, this was a case that I had, and the defendants fought very hard, especially when McCulloch came out, to say that a reasonable cardiologist would not have had such a discussion because it was aspirational best practice, and that was a strong argument that they put forward. But all experts had accepted that it was mandatory to have a discussion, and the claimant's evidence was that if that discussion had taken place, he would have commenced anticoagulation. But if he hadn't said that, I don't think we would have been able to win it. Okay, let's deal with the next one. Unless anyone's got any further questions about case study 1.
It's maybe quite a nice example of how atrial fibrillation and anticoagulation seems quite straightforward, but there's a lot of complexity to it, and depends on timing, what the risks are, etc. And it's not one of those things where have condition equals must have this treatment, which would be much easier. You know, it's if you have a fractured femur, then not treating the fractured femur is quite straightforward. That should have occurred. But it's different in cardiology because you've got differing risks, and I think that's where the complexity comes.
Okay, so case study 2, Hamlet and the case of angina. So we've got Hamlet here, that's a 45-year-old male. He's very fit and active. He regularly runs marathons. He does not smoke. And he'll occasionally have a glass of red wine, so 1 glass of red wine a week, say. When he's not training for a marathon, he's an investment banker. He works very long hours, and he holds bitter feelings towards his boss and uncle, whom he believes stole his company from him when his father died. He's very stressed at work. On the 1st of March 2024, Hamlet experienced some chest pain. He had an argument with his uncle about work. He put it down to stress, thought no more of it. On the 5th of March, Hamlet experienced chest pain again. He had been intending to go for a run, but he decided against it. He mentioned this to his wife, Ophelia. She was concerned. Again, Hamlet dismissed it. He thought he was too young and fit and healthy to have a heart problem. On the 6th of March, Hamlet experienced further chest pain whilst walking to work. It resolved after resting for 5 minutes. He also experienced breathlessness. He decided that he should consult his GP that afternoon. He saw his GP and he explained that he'd had 3 episodes of chest pain over the last 6 days. He explained that he was very fit, he was finding work stressful. He was signed off for work for 7 days for stress. On the 10th of March, Ophelia returned from her hobby of lake swimming, and she found Hamlet clutching his chest and gagging. She called 999. Paramedics attended, but Hamlet was pronounced dead on the scene. Post-mortem was performed on the 12th of March, which recorded the heart was enlarged at 437 grams, the pericardial sac, atria, valves, right ventricle and pulmonary arteries and veins were normal. The coronary arteries showed severe atheroma in the major coronary artery with 90% fixed stenosis of the left anterior descending artery, which was occluded by additional thrombus, and 60% stenosis of the circumflex. The right coronary artery was unobstructed. The lungs showed some edema. The conclusion of the pathologist that was Hamlet died of a myocardial infarction caused by coronary artery thrombosis blocking the blood supply to a large area of the heart. Breach of duty has been admitted by the general practitioner. It's alleged that but for the negligence, he would have attended accident and emergency, an ECG would have been performed, and he would have been, which would have been abnormal, leading to a diagnosis of coronary artery disease. Hamlet would have been treated with coronary artery stenting, and he would not have died on the 10th of March. The defendant maintains that the death was unavoidable. The defendant avers that Hamlet was suffering from stable angina, which would have resulted in a referral to the Rapid Access Chest Clinic. Hamlet would not have been seen before the 10th of March. The defendant further avers that had Hamlet been seen in accident and emergency, he would have been diagnosed with possible stable angina and he would not have undergone immediate revascularization, but instead commenced on medication and referred for an outpatient review. It is accepted that had he undergone revascularization, he would not have died on the 10th of March. I'll hand over to Saul to deal with the medicine.
Yeah. So this is a very common situation in cardiology, medical legal cases where patient has chest pain, sees the GP doesn't do anything about it. Sometime later, a myocardial infarction or other event happens, and if only that GP had paid more attention, then the event wouldn't have happened. And of course, depending on the situation, the outcome is quite different. So a little bit of background on coronary artery disease and the pathology that goes on, because that's quite helpful at understanding what happens. All of us, or most of us, have 3 main coronary arteries. There are occasional variations, but generally speaking 3. But each of those coronary arteries have lots of side branches. So you've got 3 main arteries supplying the heart, different amounts of the heart supplied by each artery. And if you block one of those arteries, then it causes a problem. That blockage doesn't usually happen quickly. It happens slowly over years. Build up of atheroma, which is the collection of stuff that gets into the lining of your artery, bit of cholesterol, bit of white blood cells, bit of other gunk that gets in there, and it thickens up the lining of the artery and starts to occlude the lumen of the artery so that you're restricting blood flow. And that typically, if you see towards the middle 2 on the right-hand side, that typically is what causes stable angina. So if you restrict an artery or restrict blood flow down an artery, at rest whilst you're sitting down, you don't need a big blood supply to your heart muscle, so you've got enough blood going down that artery, the heart's quite happy. When you get up and exert yourself, you walk up a steep hill or go jogging or whatever, your heart needs a lot more blood supply, and so that restriction in the artery becomes evident. And that's why you get chest pain on exertion, because the demands on your heart go up substantially, and therefore the heart doesn't get the blood supply it wants, and so it starts complaining. That is why whether the chest pain occurs on exertion is important for the diagnosis of stable angina, because it relates back to the pathology and what's going on inside the artery. That is what we call stable angina, because that process of build-up occurs over many years. And when you start to develop angina, it's something that occurs over, obviously it has to start one day, but the build-up of the atheroma has been occurring over several months beforehand. What can then happen at some other point is that that lining has a crack that develops in it, or a fissure. So rather than being a stable bit of thickened lining of your artery, a crack suddenly occurs, and there are various reasons, some of which we don't understand why that should happen, but it then becomes unstable, and that crack opens up all of that gunk to the bloodstream, and that's very abnormal. And so what your body tries to do to protect itself is to put a blood clot over that crack, because it thinks it's healing up an artery that's leaking, a bit like if you have a cut in your arm, or your arm, part of your arm gets bitten off by a saber-toothed tiger. It thinks that it needs to block off that blood supply and protect you. With coronary disease, that blood clot actually causes harm, because the blood clot then completely blocks the artery, and so you shut off the blood supply to the heart, and that causes a heart attack. So stable angina is caused by a build-up of atheroma over years, restricts the blood flow in a consistent and predictable manner on exertion, whereas an unstable event, such as a myocardial infarction, happens over minutes, and that's because a fissure occurs, blood clot forms on top, and that takes a few minutes to form, and then you get the chest pain of a heart attack. Difference being that that occurs at any time, whether at rest or on exertion, and it doesn't go away when you rest. And typically the sort of questions we ask someone to try and work out if they're having a heart attack are, how long has the pain gone on for? If it's just 2 or 3 minutes and settles, it's unlikely that it's a heart attack, whereas if it's gone on for 15, 20 minutes or more, and it's a typical sort of pain from a heart attack, which is a heavy or constricting pain around the centre of the chest, then we think that it might be a heart attack. And the reason that it causes problems is that the heart is a muscle. Like any muscle, it needs a blood supply, and so if you shut off that blood supply because the artery blocks, then that muscle starts to complain, and ultimately the muscle might die off, but it takes a little while to do so. Now, there are 2 types of heart attack, just the ones that you might hear in cases. You have an ST elevation myocardial infarction and a non-ST elevation myocardial infarction, and the arrows have moved a little bit, but it applies to what the ECG looks like. And the difference is usually down to whether you've got complete blockage of an artery or whether you've got almost complete blockage of an artery, and it does different things to your ECG. The reason why it's important, and we come back to that, is that if your artery is completely blocked, it needs to be treated right away now. If your artery is mostly blocked, then in a perfect world it would be treated right away now. But in the real world setting, which is most of the UK, it is quite reasonable to settle the patient down, put them on the wards, give them appropriate drugs to stabilise their heart, and have a look at the arteries in the next day or 3. So the important difference, although pathologically there may not be a big difference, in terms of outcomes, there's a very big difference, because you can afford to wait if your artery is very narrowed but not completely blocked, whereas you can't afford to wait if the artery is completely blocked. So in the old days it was easy because we didn't have sensitive tests for heart attacks, but now that we do, we can pick up the very small amounts of damage from the non-ST elevation type. So that's the background. Treatment for coronary disease essentially falls into 3 broad groups. We can give you drugs, and those drugs, generally speaking, do 2 things. They reduce the risk of, firstly, the atherosclerosis forming in the first place. So we reduce the build-up of atheroma in your arteries, and that's where the statins come in. They reduce cholesterol, and over the years they can reduce the build-up of atheroma. What aspirin does is it attacks the platelets, the little sticky cells within the blood that cause blood clots to form in the first place. And so it's like a weaker form of anticoagulation but it's very good at preventing heart attacks in particular. What we also do is give you drugs that reduce how much the heart suffers from angina, and these drugs will either open up the arteries to the heart or they slow the heart down and therefore ease the work of the heart that way. So you have drugs that are good at preventing future events, aspirin and statin, and you also have drugs that treat the angina, the exertional chest pain, and make the heart of the work easier. And it's quite acceptable to treat patients with just tablets. There are many patients who have stable angina. You give them aspirin and a statin to prevent future problems, and you put them on bisoprolol, for example, which we also use to treat angina. And their angina could be treated very successfully that way, and they don't necessarily need anything else. So that's option one. Option two is we go and have a look at your arteries. We see that there's a very narrow section, and we want to open it up. And we would do that by passing a balloon inside your artery. These days we normally go in from an artery in your wrist. We make a small hole in the wrist with a local anaesthetic, pass a long thin plastic tube up to your heart. Having released a dye to take the pictures, we then pass another wire along that tube inside the artery, and then put a balloon along that wire and stretch up the balloon inside the very narrowed section, so we open up the artery. It's what plumbers do these days, often in pipes and things within the house and sewage systems, except their balloons are somewhat bigger and stronger than ours. So that works very well, and then we put a stent in, which is like a miniature metal scaffold. So having opened up the artery, we put a metal scaffold in, and that helps to keep it open. Option three, if you've got a lot of disease in many bits of those three coronary arteries, then we might offer you surgery, which bypasses, as the name suggests, bypasses those three vessels. So what we do is we take a bit of artery or a bit of vein, attach it higher up in your system to the main artery coming out of the heart, the aorta, and then we plumb it in beyond the blockages. So it's a bit very much like taking a bypass in a town, for example, where you've got little narrow streets in the centre of town that are congested. You build a bypass around the side and you gain access to the town a bit further down. And it's kind of the same principle. The heart gets its blood supply via these extra arteries. And generally speaking, if you've got atheroma in one or two arteries, we'll treat it with angioplasty. If you've got atheroma all over the place, then we'll treat it with bypass surgery. Now, the interesting thing is about preventing a heart attack, because those treatments really are for stable angina, and we can be very effective at treating your angina in most cases. Preventing a heart attack, however, is done by a number of things. Firstly, we advise patients on their lifestyle. We want to lose weight. Stop smoking probably has a 50% reduction in risk, but that all takes a bit of time. And on the whole, those lifestyle factors, whilst important, don't produce enough of a reduction in the risk of a heart attack that you could say, on the balance of probabilities, we'd have avoided the heart attack. So, I have had a case where the claimant argued that if only they'd been told they might have had coronary disease, they'd have changed their lifestyle and they wouldn't have had the heart attack a year or two later. And I was acting for the defendant and said, well, yes, changing their lifestyle would have modified their risk, but not enough to have prevented the heart attack. Secondly, we can give you, I don't know where I think that's come along there. Yeah, so risk factors get across because whilst they do reduce your risk, it's not sufficient to avert a myocardial infarction on the balance of probabilities. Aspirin and statins actually have a really good impact on your risk of a heart attack. Aspirin alone, or statins alone, probably reduce your heart attack by about 30-40%, and aspirin by a further 20 or 30%. So on their own, each of them isn't quite enough to result in a greater than 50% reduction in events, but both together is just over 50%, depending on the slight situation. So interestingly, tablets get a little tick because it's only just over 50%, but what's surprising to some is that aspirin and statins are actually very effective at reducing the risk of myocardial infarction in the future. Timing is important. Aspirin works very quickly, within hours, probably within a day or two, you're up to maximum impact, whereas statins, their primary impact is on reducing the cholesterol, which then has an effect over years in reducing your risk of events. So unfortunately, your statin does need to be started a year or two beforehand. So that claim only really works if you've got sufficient time, a couple of years, for example, at least. Most of the trials are 3 to 5 years of the statins, so then I could say we're confident. Whereas if you would have started your medication a month beforehand, that just isn't time for the statin to be sufficiently effective. So whilst you'd have a good reduction, not more than 50%. The really surprising bit is that if we go in and open up that narrowed section of your artery, we don't, in fact, reduce your risk of a myocardial infarction sufficiently to have prevented it on the balance of probabilities. And that's really surprising to most people, because you'd think that taking away that narrowing takes away your risk of a heart attack. What you have to remember is that that angioplasty is only like spot welding. You're dealing with that narrowing in that one bit of the artery, but you're not treating all of the rest of the arteries like the drugs do. So if you've taken away that one narrowed section, your crack in the lining of the artery that then goes on to cause your heart attack might have occurred where your very narrowed section of the artery was, but it also might have occurred at any other bit within your coronary artery tree. And because there are more other bits in the coronary arteries, it's more likely that the heart attack would have occurred in some other part of the coronary tree. So unless you can show, which is occasionally the case, that that very narrowed section that would have been identified was the point at which later caused the heart attack, that's the kind of exception to the rule where you could say, yes, getting rid of that narrowed section would have worked. But otherwise, actually, angioplasty for stable angina would be very good at treating the angina, but would not, in fact, on the balance of probabilities, have prevented the heart attack 6 years later, or 6 months later. So that gets across, which is surprising to most people. Coronary artery bypass surgery, I put a question mark down because there is some data to show that it prevents heart attacks over the next few years. It probably works within months, but the difference of effect is moderate. We're probably talking about a 20 to 30% reduction in heart attacks on average. So some people might be more, some people might be less. That's why I put the question mark there, because it does reduce your risk of a heart attack, but not by 50%. So that's our treatment for myocardial infarction. Did you want me to go on to the cardiac arrest versus thing now? This is just a small aside, but particularly for lawyers, it is often really confusing to understand the difference between a cardiac arrest and a myocardial infarction. Most members of the public think they're the same thing. Cardiac arrest equals heart attack. And that's not surprising, because if you think about the words heart attack, yeah, it sounds like heart stops, which sounds pretty much the same thing. In fact, they're quite different. A cardiac arrest, as the name accurately describes, does mean that your heart has stopped. And it's usually stopped because it's gone into a really abnormal rhythm, such as ventricular fibrillation or ventricular tachycardia, not to be confused with atrial fibrillation, or some other reason why the heart has stopped. And the minute that happens, your brain and other organs are deprived of oxygen, and very quickly, within 3 or 4 minutes, you run into trouble. And unless we get your heart started really in under about 3 or 4 minutes, the likelihood is that you'll die because your heart stopped. A myocardial infarction, where the artery blocks, it causes damage to the heart, but the heart still keeps beating. And although you might end up with a scar in that heart and the function of the heart is ultimately reduced, most of the time, people who have a myocardial infarction survive, do well, have a good quality of life for many, many years. And so although they sound intuitively like they might be a similar thing, they are actually quite different. Just to make life really confusing, cardiac arrest can be an infrequent complication of a heart attack. So one can follow the other, but they don't always do so, and it's important to understand the distinction. So, back to the questions.
Right, thank you. That's very, very interesting. So let's look at the questions then. How are we approaching this case? So, was Hamlet suffering from stable angina, unstable angina, or a myocardial infarction on the 1st, 5th, and 6th of March? So, on the 1st of March, who thinks he was suffering from stable angina? Put your hands up. Yeah, I think that's probably right.
I'd say with hindsight, yes.
Yes.
On the 1st of March, we just had one episode, so I'd say a little bit difficult to say.
5th of March, stable angina, do we think?
Yeah, then I'd agree. You've got several episodes, predictable, happening on exertion, pretty good description of stable angina.
And the 6th of March, I think that's stable angina again. Yeah.
Yeah.
And why is it not unstable angina then?
This is an argument, a discussion I have often with my cardiology opposite numbers. It's not unstable because it is predictable and consistent. It happens on exertion and is relieved by rest. It doesn't happen at rest and then persist for a prolonged period of time, say 15 or 20 minutes, which is the sort of pattern that we'd expect to see with unstable angina. You've clearly put here that even on the 6th of March, he had further chest pain whilst walking to work, which resolved after resting for 5 minutes. That is a very classical pattern for stable, brackets, predictable angina.
Okay, so we're approaching this case and we're pretty confident that we can say that in the episodes leading up to his death, he had stable angina, some episodes of stable angina. So, assuming that an ECG was performed on the 6th of March, because the allegation is that on the 6th of March was when he went and saw his general practitioner and that he should have been told to go to accident and emergency. Assuming that an ECG had taken place, would that have shown, I've phrased it as concerning changes, which isn't particularly well phrased, but I think you get the point. Would it have, if an ECG had taken place, would it have revealed evidence of an underlying pathology?
No.
No.
ECGs are performed at rest. If your heart is happy at rest because it's getting sufficient blood supply to the heart muscle, then I would not expect any changes on your ECG.
So he's gone to A&E, he's at rest, he's had some chest pain, but the ECG is not showing anything which would cause concern. I'm right in thinking, though, that if he were having a myocardial infarction, that would show up on an ECG?
Yes.
Yes. So we can be pretty confident then that on the 6th of March, he definitely wasn't having a myocardial infarction. All right, so question 3. If a diagnosis of unstable angina, which should say stable angina, was made in accident and emergency, would Hamlet have undergone revascularization or commenced on medical therapy, statins and aspirin? Who thinks medical therapy? Yeah, I think they're probably right.
Yeah. I must have been paying attention.
Yeah, good.
You've slightly missed out a step there as well, which is, did you need to go to accidents and emergency?
Well,
I don't know if that was deliberate.
it sort of was, because that's how the claimant would have to run
I see what you mean.
the case. The claimant will have to run it to say, as I often have seen, I'm sure you've all seen as well, chest pain, multiple episodes of chest pain means go to accident and emergency. And a lot of GPs that I speak to, whilst they will say, well, it depends, a lot of them err on the side of caution when it comes to chest pain. But you could have an interesting argument with a GP about that.
So an alternative GP might say, what I would have done is refer them to a chest pain clinic rather than the emergency department, because that would be the standard approach. And certainly if a GP had done that, I think it would be well within the range of acceptable practice. Obviously I'm not a GP.
But that chimes with what they tend to say. Would the situation have been different then if he did go to accident and emergency or was diagnosed with unstable angina?
If he was diagnosed with unstable angina, yes, they'd have admitted him to hospital and probably carried out a coronary angiogram. You'd have to say that it was likely that he was having unstable angina in order for that to be the case. I think it would be too difficult to say that although he was having stable angina, the emergency department would have misdiagnosed him with unstable angina because they were risk averse and therefore admitted him to have his angiogram. I think that's a bit of a hard argument to make.
Okay, so the last question, just before we get to that, the final sentence of the case study, the defendants in this instance have accepted, so presume in letter of response, that had he undergone a revascularisation, he would not have died on the 10th of March. Who thinks the defendant should have made that concession? Who thinks that there would be evidence to say, presumably in discussion with their cardiologist, that if a revascularisation had occurred, that he would not have, that he would still have died? So thinking about what Saul said about the difficulties of if you're putting in a stopgap, a temporary plaster, would somewhere else have just fissured, causing the myocardial infarction? I think that's a very difficult question, and I've had one particular case that springs to mind where it turned into a real argument about whether or not they could tell which area of blockage effectively was going to rupture to cause the myocardial infarction, and the claimant's cardiologist was adamant that you could. I think there was a healthy amount of hindsight that he was applying, whereas the defendant's cardiologist was adamant that you couldn't tell. So that might have been a concession the defendants maybe shouldn't have made. So would revascularisation or medical therapy have prevented the myocardial infarction in this case? Who thinks that the medical therapy would have? Who thinks that the revascularisation would have? So let's assume that it's accepted between the cardiologists that they could tell which, where the fissure would take place. So if they could tell where it would take place, who thinks that the revascularisation, the stenting, would have prevented the myocardial infarction? What do you think?
Yeah, I think this is an interesting case because he's got a very narrow section which then had the blood clot. So this is one of those rare cases where we do know where the blockage occurred, and it was on the bit of the artery that had the narrowest section. So it is the point where you would have put your stent, and therefore probably the myocardial infarction would have been prevented, even though in most cases the answer would be no. I think he's the exception where the stenting would have worked.
Okay. And what about medical therapy? Who thinks that the medical therapy would have prevented the heart attack? How long does the medical therapy take to work?
Aspirin's quick, but the statins, how long do they take?
Months, if we're being generous. Yeah.
Yeah.
Yes, you're right. So you would have had a very good benefit from the aspirin, sort of 30% reduction in risk, but that's not enough on the balance of probabilities. You wouldn't yet have had the benefit from statins.
So who's taking this case on as a claimant? Who's defending it as a defendant?
A few days.
This is a really difficult case. It sort of gives with one hand but takes away with the other. A lot would have to go right for the claimant. And I think the biggest thing that works against the claimant is when he presented at accident and emergency, he was suffering from stable angina, which wouldn't have led to an admission. He would have been probably given a cardiology outpatient appointment. Would accident emergency give him statins?
Not normally, no. They'd advise the GP to start it.
So it looks like he's going to go to accident and emergency and be given a preliminary diagnosis, but then a routine referral is going to be made. But we know that it would be highly unlikely that he would be seen within clinic before he died on the 10th of March. If the stars somehow aligned, and although I think it would be very, very difficult, because we know where the occlusion was in this case, that they could argue that an angiogram had taken place and revealed that. But that seems highly unlikely.
I think the time scale here is against the claimant because it's really, really short. The one thing that I have seen used to try and align the stars is private health insurance. So sometimes people say, but I've got private health insurance, and if only my GP had told me this could be my heart, I'd have seen a cardiologist pronto, and so I'd have seen him or her the next day, and they'd have had me in for an angiogram the day after that. And I have seen that argument made, and there's some logic to the process.
I had a case where the argument involved the prognostic benefit, whether or not the claimant would have had a benefit from a revascularization in a case of stable angina that was controlled appropriately by medication. And that was an interesting point, because the claimant's cardiologist said that there was a prognostic benefit, which we said there wasn't, and the judge agreed with him, which still rankles, but there we go. Okay, so this is a case which, as Saul said, it's very common that you'll see. It's almost like a bread and butter heart attack case with your cardiologist, and the timing is really against the claimant. If he had started to show symptoms at the end of 2023, your timing is starting to become more on your side as a claimant. But when you are looking at preventing heart attack cases, the first and most important thing you should be looking at is timing. Because if you don't have the timing, you're not going to persuade a judge, because we know what the experts will say is that the medication takes time to become effective. And that's where they often fall down from a claimant. And you will usually tell from a claimant's side when the defendants are feeling very bullish about it, because they'll go straight to the timing aspect of the case to say that the death was unavoidable. Okay, who's got any questions about case study 2 then? Who's got any questions generally? Okay, well no, that's great. Thank you, as I say, all of you for coming. I hope you have found it interesting. Cardiology cases are difficult, as I think today has demonstrated. They're not black and white, and there's a lot of competing interests and balancing of risks, which it's easy to be overzealous from both sides of the litigation, from a claimant and from a defendant, but they're usually nuanced arguments. Both of these are focused slightly more on the causation side, which again still seems to be where the majority of cardiologist input is. But as I said at the beginning, there do seem to be increasing numbers of cardiology breach of duty cases coming through, which is interesting. And I think, Saul, you said that reflects perhaps more an expectation of cardiology treatment as opposed to whether or not there is actually an increasing negligence amongst cardiologists, which would probably chime true with the types of cases you'll see come across your desks. So, unless there's anything further you wanted to add at this stage, Saul? Those who want to, we're going to go for a drink, and you're of course more than welcome. But otherwise, as I say, thank you all very much indeed for coming this afternoon. Thank you.